Well, thank you so much indeed for coming at this early time. And yeah, I feel a bit an intruder because this first session is about MRI, but you will hear a bit about also synaptic PET in this talk. So yeah, I think most of you already saw this scheme presented by James Rowe at some point in his life, and but he captured quite well the complexity of what we have behind dementia, like the syndromes and clinical manifestation of neurodegenerative diseases. And basically, this is like the cascade that goes from protein aggregation, inflammation, but also synaptic dysfunction and cell death. And with different techniques, we can explore now in vivo, in patients, these different parts of the cascade. With the positron emission tomography, we can look at something that is upstream in the cascade, like inflammation, synaptic dysfunction, the aggregation of tau, amyloid. And with MRI, we can look at connectivity, cell death, and neurotransmitters. So today I will show you some results on frontotemporal dementia. For who is not familiar with frontotemporal dementia, is a spectrum that encompasses like a lot of different clinical manifestations that can manifest with behavioral symptoms, language, cognitive impairments, but also some movement disorders. And it's very complex what is behind these clinical symptoms. Symptoms can be sporadic, genetic, and associated with different pathology. In this spectrum, MRI has been super helpful for diagnosis, prognosis, and in particular, in the years, basically, MRI have been included in clinical practice to confirm the diagnosis after seeing symptoms, guessing which was the particular diagnosis, and then people go to the MRI scan, and we can see where the atrophy is localized in the brain. So behavioral frontotemporal dementia is bilateral in the frontal lobe, semantic dementia is more in the left temporal pole, etc., etc., etc. However, in Cambridge, we are trying to move from MRI to 3T MRI to new technology, new methods to look at frontotemporal dementia. And in particular, in the last few years, we started to look at 7T MRS for neurotransmitters. There is Michelle, who is doing a PhD on that. And there is also the ultra-high field 7T MRI for small structures, like the locus coeruleus. But also we started this new PET ligand for synaptic density that I will explain a bit more. So for synaptic density, we are using UCBJ PET here in Cambridge, which is a tracer that binds the synaptic vesicle glycoprotein 2A, and it is a marker of the presynaptic terminals. With basically, patients comes to the PET scan, they are injected with this tracer, the tracer goes to the brain and binds these vesicles, and with fancy methods, we can reconstruct the signal in the brain, and we can identify where the synapses are and how many synapses these people show. And this is a picture of a control, and as you can see, higher signal is represented by orange and red regions, and in a normal, healthy brain, the synapses are in the gray matter, and those regions that are blue are white matter, so like low synapses, of course. So this is a mean of the controls across 25 controls in our study. And basically, we used the same technique to look at our patients. And this is an example of 4 patients that we recruited in our study with frontotemporal dementia, behavior variant of frontotemporal dementia. And across the different patients, there is also different severity in terms of synaptic density. And as you can see, the patient 1 is quite healthy, let's say, because they have still a lot of orange and red regions, while other patients show like a bit more blue. So basically, the synaptic, the blue regions are those regions where the patient lost their synapses. And across all patients, because of this particular syndrome and this particular pathology, we found a common synaptic loss in the left frontal region. Left frontal region. So then we basically wanted to identify if this synaptic loss also was clinically relevant. So we correlated the synaptic loss identified with the UCBJ PET with cognition using the ESR, the Edinburgh's Cognitive Examination, which is a scale that goes from 0 to 100, where 100 is normal and 0 is very severe. And we identified a strong correlation, both using the frequentist and the Bayesian approach, with a strong correlation between synaptic density and cognition. So as you can see, the patients in orange is one that performs quite well in this cognitive test, while the patient in purple is a patient that performs very poorly in the cognitive assessment and has quite a bad synaptic loss in the left frontal regions. And also we look at how early we could identify this synaptic loss, and we look for that in genetic FTD. When these patients carry a specific gene, we look at daughters and sons, and if they carry the same gene, it is very likely that they will develop the same type of dementia. So we basically scanned the C9orf carriers when they were still symptom-free, so we could identify the change in the brain while they were not manifesting the symptom yet. And as you can see, in this carrier, the brain looks quite healthy, like a control. However, if you focus on the thalamus, you see that there is like a lower signal in the thalamus. And we identified this systematically across three different carriers, being able to identify synaptic loss even 20 years before the estimated years of onset, of the symptom onset. So then, where is MRI on all this story? Basically, MRI is always our safety, like our safe friend. So basically, we use that in clinical practice to look at the different impairment in the brain where the atrophy is localized. So when we identify a new marker, we always go back to MRI and we try to understand what the new marker can bring in terms of added value. And in particular for the synaptic PET, we wanted to be sure that we were not just picking up atrophy and we were not picking up something that you can easily measure with just structural MRI. So we compared the two techniques. So we did different approaches to compare the two techniques and be sure that what we were looking at was something else. Simple comparison, we basically look at the group comparison of UCBJ PET and gray matter volumes. And what you can see is that synaptic PET showed quite an extensive patterns of synaptic loss in comparison to what you could identify in terms of atrophy and gray matter volume loss in the same patients. So these are 11 patients, not a very big sample, but they are very tricky patients, and we were during COVID, and PET imaging is quite expensive as well. So this was the quite an adequate sample size, and with such a small sample size for other techniques, we found quite strong effects with synaptic PET. And it is quite major in terms of both effect size and spatial extent. And this is also like, this is just to show you, so this is basically plotting both the multiple comparison uncorrelated results and the FWE correlated results, and this is just to focus on what remains when we plot just the correlated results. So you see that the gray matter volume loss is quite restricted in comparison to UCBJ PET. Then to be sure, we compared also region-based analysis we applied. So basically, we used the scan-specific voxel-wise maps. We applied this Hammer's parcellation, which involves 83 regions across the whole brain. In each region, we extracted the average binding potential, so the PET signal, and the total gray matter volume, which was corrected for total intracranial volume. And then we calculated the regional z-scores for each technique, comparing patients versus controls. And as you can see, also comparing the z-scores, again, UCBJ PET showed quite a more extended pattern and more severe loss in comparison to controls than gray matter volumes. but we wanted to be super sure that it was a valuable result. So we applied other 3 validation comparisons, and there are three different approaches. So the first one was comparing the z-scores and effect size. Basically, we compared the mean z-scores of gray matter volume and UCBJ across each region. We compared the mean and also the Cohen's d effect size when we compared the z-scores, the gray matter volumes and the UCBJ between patients' controls. And we identified that 84 of the regions had larger negative UCBJ effects than gray matter volumes. So this was still a confirmation that UCBJ was picking up something stronger than gray matter volumes. A second approach was the logistic regression. So basically we compared we included MRI. For each region, we included the individual MRI values, and with the outcome measure was groups, so controls and patients. And then we compared this simple model with the model including the same region UCBJ value. And so basically then we used the AIC to compare the 2 models to identify which was the best. And in all regions, basically, including the UCBJ term, showed that there was an added value to improve the fit even after penalization for increased model complexity. So in this previous comparison showed that we had a stronger effect with the UCBJ, while this comparison showed that UCBJ explains something that on top of atrophy, not just atrophy, that is explained by gray matter volumes. Not happy about that, just to be super sure that we were seeing this. We also corrected the UCBJ values for gray matter volumes using a simple linear regression model and extracting the residuals. Basically, we used as X variable the regional gray matter volumes, and our outcome was the regional synaptic density, and we extracted the residuals. With this approach, basically, we wanted to see which part of the variance was explained by just the synaptic loss after corrective for atrophy. And then we used the residuals to compare the 2 groups. And again, most of the brain regions still show significant reduction in patients versus controls, and none showed the opposite effect. So even after clearing up the effect of gray matter loss, we saw a difference between the patients and controls. So just to summarize, synaptic PET, I show you that synaptic PET in frontotemporal dementia quantifies synaptic loss at single subject but also group level, relates to clinical severity, and precedes symptoms. When we compared synaptic PET with 3T MRI, it was more sensitive in terms of spatial extent and effect size. And today I just show you 4 different approaches that we use to compare synaptic PET and MRI to be super sure that this was not related to the approach that we were using, like, for example, voxel-wise or regional-based analysis, and to be sure that what we were measuring was something in addition to atrophy that we could easily identify with structural MRI. So I think it's pretty robust result. I just want to thank you for the attention, to be here super early, and all, of course, members of the Cambridge Center for Frontotemporal Dementia, the volunteers and family and funding. Thank you so much.